Hello everyone. Today we are going to discuss the aortic dissection. First, we'll talk about the case. So, we have this 31-year-old male patient who came with chief complaint of right-sided weakness, headache, and the right-sided vision loss since one day. Then he brought to emergency department. On arrival to the emergency department, patient was intubated because of the low GCS. Total NIHS score was 21. MRA was done, which showed the multiple infarct of the right hemisphere with occlusion of left MCA and IC. So patient underwent mechanical thrombectomy. So after mechanical thrombectomy, the patient was persistently hypotensive. 2D echo was done for this patient, which suggestive of aortic dissection. And the 2D echo picture was like this. We can see the flap in the aorta. So there was only suspicion of the aortic dissection. So we had done CT chest with abdo, which showed the tennis ball sign, which was suggestive of the aortic dissection. So we'll have the brief discussion of aortic dissection now. So we will see with the help of this article, we will see how to manage the aortic dissection in the critical care. So aortic dissection is associated with the significant mortality and morbidity, often requiring immediate intervention. So regarding pathophysiology and classification, aortic dissection described a tear in the intimal lining of the aorta extending into the media of the wall. So the blood flows through this tear, leading to the formation of the false passage bordered by the inner and the outer layer of the media. Connective tissue diseases like Marfan, Ehlers-Danlos syndrome increases the risk of dissection due to weakening of the media. Other causes include atherosclerosis, trauma, inflammation, and or infective and iatrogenic condition. So we will see now the classification of the aortic dissection. So there are two classification. One is Stanford classification and the other one is Berkey classification. According to the Stanford classification, it involves the dissection in relation to their involvement of ascending aorta, and it is divided into type A and type. Type A involves the ascending aorta plus arc of aorta or descending aorta. Type B Type B does not involve ascending aorta, but it involves the descending aorta and the abdominal aorta. Now, according to the Berkey classification, the aortic dissection is divided into three types: type 1, type 2, and type 3. Type 1 originates into the ascending aorta, involves ascending aorta, aortic arch, and the descending thoracic aorta. Type 2 involves only ascending aorta. Type 3 originates distal to the left subclavian artery and further classified into 3A and 3B. 3A is limited to the descending thoracic aorta. 3B is extending below the diaphragm. So this is the pictorial representation of Stanford classification and Berkey classification. So it is the So, regarding Berkey and Stanford classification, we have it was already explained. Now, regarding the diagnosis of aortic dissection, the presentation of the Stanford A aortic dissection may include severe chest pain, syncope, aortic insufficiency, pulse differential, myocardial ischemia, and neurologic sign. Presentation of the Stanford B aortic dissection may include the severe chest, back, or migrating pain, distal pulse differential, limb pain, claudication, renal insufficiency, and high blood pressure. So several investigation can be used to help rule in and out aortic dissection, ranging from bedside test to magnetic resonance imaging. So first we will see the CT finding. Computed tomography remains the first line imaging for definitive diagnosis of aortic dissection. It is readily available in most hospitals and allows for the characterization of the type, position, and size of dissection, alongside identification of potential differential diagnosis. For example, pulmonary embolism. However, unlike echocardiography, it requires transfer of the patient and thus may not be immediately possible in hemodynamically unstable patients. So the preferred protocol is non-enhanced CT followed by contrast enhanced CT angiography. And to assess the full extension of dissection, the scan should extend from chest all the way down to the pelvis. And the presence of visible dissection flap has previously been described as tennis ball sign. So this is our CT tomography imaging demonstrating tennis ball sign in type A dissection, and that's shown into the figure 1, and in the figure 2 there is a type 2B type B dissection. Now regarding echo point of care ultrasound echocardiography, both transthoracic and transesophageal echocardiography can be utilized in the diagnosis of acute aortic dissection. Their ability to rapidly diagnose the aortic dissection at bedside is potentially life-saving. Transthoracic echocardiography has the advantage of being invasive than transesophageal echocardiography and more easily available. So the suprasternal echocardiographic window will allow for visualization of arc of aorta. Now regarding abdominal aorta scanning, ultrasound examination of abdomen allow the identification of aortic dissection extending down to the abdominal aorta. The aorta is examined in transverse and the longitudinal section, with typical appearance being presence of flap or thin membrane fluttering within the vessels. So the echocardiographic finding in the aortic dissection includes dissection flap, and echocardiographic appearance include mobile linear echoic line separating the true and false lumen, then aortic valve disruption. Aortic regurgitation may be seen if dissection extend to the aortic valve. Then there is a presence of pericardial fluid, visualized as anechoic fluid in the pericardium sac. Then aortic root dilatation, index to the height according to the BSc guideline. Then regional wall motion abnormality, area of the regional wall motion abnormality depending on the coronary territory affected by the dissection. Now regarding magnetic resonance imaging, it has a high sensitivity and specificity for detection of aortic dissection. The use of MRI is limited by its availability, prolonged scan time, challenges associated with the monitoring and contraindication in patients with metal implants such as pacemaker. And the next investigation is ECG. Aortic dissection may result in abnormal ECG finding, which can distract the clinician. More than 70% of the patients with type A aortic dissection have an abnormal ECG. And the ECG may be presented with the following finding. There can be ST elevation in 8% of patients. This is closely related with the direct coronary involvement. Then ST depression in 34% of patients and T wave changes in 21% of patients. The presence of ECG changes are associated with increased incidence of shock and cardiac tempo. Then the next is chest X-ray finding. Traditional teaching emphasizes the presence of widened mediastinum in patients with type A aortic dissection. It is, however, important to recognize that more than 20% of patients with type A dissection do not have this finding, and it should therefore not be used as rule out investigation. And cardiomegaly may also be present in case of pericardial effusion or aortic valve incompetence secondary to the aortic dissection. Now the next investigation is biochemical marker. So D-dimer is one such biomarker. A meta-analysis assessing its use in the diagnosis of aortic dissection found a D-dimer of more than or equal to 500 Ng per ml is associated with 97% sensitivity and 56% specificity. This corresponds to the negative predictive value of 96% and positive predictive value of 60%. This result highlights the potential role for the D-dimer in identifying patients without aortic dissection. However, the role of biomarker is significantly limited in acute scenario where time cannot be afforded to waiting for results, and thus they are likely useful only as a rule-out tool in potential chronic presentation. Now regarding management, aortic dissection management. So initial management. When managing acute aortic dissection, the initial treatment should concentrate on resuscitation and stabilization of patient while deciding and preparing for definitive intervention. Now regarding blood pressure management, tight blood pressure control and the reduction of the rate of blood pressure rise during systole is vital to reduce the chance of dissection propagating further. The shear force within the aorta is defined by change in pressure over time. In the absence of aortic regurgitation, the first line antihypertensive agent is beta blocker, targeting the heart rate of 60 to 80 beats per minute and systolic blood pressure of 100 to 120 mmHg. The primary drug choices and example regimen include the following drugs. So these are the drugs that we can use while controlling the blood pressure. So first drug is ismolol. A loading dose of 200 mics per kg per minute is given, followed by the infusion of 50 microgram per kg per minute for 4 minutes. Then the next drug that we can use is labetalol, an initial bolus of approximately 0.25 mg per kg with further boluses at 10-minute interval as required. Then the next drug that can be used is metoprolol, which is given as a bolus of up to 5 mg, repeated at 5-minute interval if required up to 50 mg. Although labetalol is frequently used for the blood pressure control in this clinical setting, it should be borne in mind that drug has the elimination half-life in the excess of 4 hours and that changes in the rate of infusion will not yield steady state plasma level for 16 to 12. In patient intolerant of beta blocker, non-hydropyridine calcium channel blockers such as diltiazem and verapamil are accepted alternative. The use of vasodilator may also be required to aid rapid blood pressure control. And this includes sodium nitroprusside, which is given as an infusion titrated to the effect at 0.5 to 1.5 microgram per kg per minute. Then glyceryl trinitride given as an infusion titrated to the effect at 2 to 10 mg per. Both the sodium nitroprusside and the glyceryl trinitride produces the reflex tachycardia that exacerbate myocardial ischemia. Now we will see the overall management of the aortic dissection. If we are suspecting aortic dissection, then the target should be SpO2 should be more than 95, HB should be more than 12, systolic blood pressure should be more than is in which should be between 100 to 120, heart rate should be 60 to 80. Then we should stabilize the patient initially, manage the ABCD, then secure the wide bore cannula for heavy access and the blood transfusion if required. Then invasive BP monitoring and the tight BP control is needed. Ensure the adequate analgesia. Then go for the diagnostic image testings like CT, MRI, bedside transthoracic echocardiography and transesophageal echocardiography. Then take the surgical opinion of the surgical team and decide whether the intervention is required. So the decision of the surgical intervention is depend upon the type of dissection. If it is a type A dissection, go for the surgical intervention and plan for the open surgical repair. If it is a type B dissection, then go for the surgical intervention only if it is a complicated. If it is an uncomplicated, then medical management. So the how to decide whether the this aortic dissection is complicated or not. So complicated type B aortic dissection includes persistent refractory pain, malperfusion, then rupture or leak, and rapid extension of the false lumen. And consider transfer if definitive treatment is not available at your setting, like resuscitate and stabilize. During transport, make sure the proper resuscitation should be done. Patient should be stabilized. Ensure the competent team is competent. Monitor as per guideline. Plan for the deterioration and establish if scoop and run is indicated. So when it comes to transfer, so what precautions we need to take? The patient presenting to the non-specialized center will require the urgent transfer to the cardiothoracic center. So during transport, the physiological monitoring should be done, which include electrocardiography, intermittent non-invasive blood pressure measurement, pulse oximetry, continuous invasive arterial pressure monitoring should be used in patient receiving antihypertensive drugs. Then regarding surgical treatment of the acute aortic dissection. Type A aortic dissection, surgery is the standard treatment for acute type A dissection. And the basic principles are to resect the primary tear, establish the blood flow in the true lumen, replace the dissected intrapericardial aorta. Surgery should generally be undertaken as soon as possible after diagnosis. And surgical strategies depend upon the many factors, like anatomy of dissection, which include the primary intimal tear location, aortic dimension, and the aortic valve condition. Then patient factors, including age, comorbidities, redo surgery, Marfan syndrome, and other aortopathy. Then dissection related complications, especially malperfusion, which may alter the management plan. In the presence of significant malperfusion, especially bowel ischemia, initial treatment may be endovascular fenestration to restore blood flow in the true lumen and then surgery. So the common surgical procedure include replacement of ascending aorta with interposition tube graft, replacement of ascending aorta with the interposition tube graft and the aortic valve replacement, replacement of ascending aorta with interposition of tube graft and the aortic valve repair, then aortic root replacement, replacement of whole or part of aorta, and frozen elephant trunk technique. And surgical principles are they have to initiate cardiopulmonary bypass and measures for the cerebral protection like deep hypothermic circulatory arrest, antegrade cerebral perfusion. Then spinal drain insertion. Although insertion of the cerebrospinal fluid drain is commonly used prior to the elective major thoracic aortic surgery, preserve pressure of time and concern about adverse impact of impaired coagulation in the presence of acute type A dissection deters many clinicians from using them. Now, the role of spinal drain in major thoracic and thoracoabdominal aortic surgery is to maintain stable intrathecal pressure to reduce the risk of paraplegia. Now, when after surgery, when the patient is coming to the ICU for post-op care, then we need to be aware about the early post-operative complications. So the early post-operative complications include bleeding due to coagulopathy associated with hypothermia and prolonged cardiopulmonary bypass, then persistent or new malperfusion. So, this pre-operative malperfusion may persist after surgery, or the alteration of the dynamic blood flow between the true and false lumen after surgery may cause new malperfusion. So, the malperfusion is generally treated with the interventional radiological technique. Now, the post-operative spinal cord perfusion optimization. Spinal cord ischemia is a significant potential complication following aortic dissection repair. So the post-operative management should include neurophysiological, intracranial and intrathecal pressure monitoring and CSF drainage for up to 72 hours. If neurological deficit is identified, measures should be instigated to optimize spinal cord perfusion and thus negate its propagation. The COPS protocol describes an approach to its management. So COPS protocol stands for C, that is CSF drain status. If malfunction, then replace the drain. If normal, ensure the patient is flat. Drain pressure should be less than 5 mmg and drain for 7 days. Then oxygen delivery optimization, aiming for SpO2 of more than 95, hemoglobin of more than 12, and cardiac index of more than 2.5. And then patient status assessment, which include a blood pressure, MAP more than 90 mmHg, spinal cord perfusion pressure more than 80 mmHg, and the patient's cognitive status. The type B dissection. The first line treatment of the type B dissection is medical management, control of the blood pressure, and analgesia. Approximately 90% of type B dissection can be managed in this way in acute setting. However, intervention is required if type B dissection is complicated. Now, complicated type B dissection is characterized by persistent refractory pain, malperfusion, rupture or leak, rapid aortic expansion, and dilatation. An endovascular intervention, placing covered stent over endometrial in the descending aorta. So if it is a complicated, then the intervention is required, and the typical intervention would be endovascular intervention, placing covered stent over entry tier in descending. And to ensure adequate proximal landing zone, it may be necessary to occlude left subclavian artery. Now, when not to occlude. All type A dissection cases need to be discussed with cardiac center, as decision not to operate is complex process. So multiple factors are considered in the decision process, including patient's age, frailty, previous cardiac surgery, dementia, and malignancy. Stroke and malperfusion is not a contraindication for the surgery. Now, post-operative care. So first part is analgesia. Patient may benefit from the epidural catheter insertion, but it is important to maintain the balance between sensory and motor block, so analgesia can be maintained while permitting mobilization. Then therapist input. The main post-operative physiotherapy priorities are prevention of secondary respiratory complications, early rehabilitation, non-pharmacological management of delirium, and education. So post-operative pulmonary complications are frequently reported following aortic dissection. Between 15 to 55% of patients develop acute respiratory dysfunction post-operatively, leading to increased number of days requiring mechanical ventilation and longer ICU length of stay. So physiotherapy aim to reduce the incidence of this complications by increasing lung volume, removing secretion, and reducing the work of breathing. Early mobilization should be the first line post-operative rehab approach unless contraindicated. When early mobilization is not permitted, further strategies can be utilized, including optimization of patient positioning, mechanical insufflation, exsufflation, and non-invasive ventilation. Now, regarding rehabilitation in the critical care is provided following comprehensive individual assessment by physiotherapist with formulation of rehabilitation plan and patient-oriented goals. The assessment of the patient in critical care occurs within their 24 hours of admission, and thus physiotherapists are in the prime position to detect any neurology symptom. Spinal cord infarct is the rare and serious complication following aortic dissection repair and occurs in 1 in 130 patients. Post-operative cerebral complications are common post-operatively and includes new onset stroke, syncope, delirium, and coma. So physiotherapists play a key role in non-pharmacological management of delirium, and this include early mobilization, daily orientation, engagement with patient family members. Spontaneous awakening, breathing trial, sleep promotion, daily assessment of the delirium using tools such as confusion assessment method. In addition to respiratory care and rehabilitation, physiotherapists promote healthy lifestyle changes through education and referral to the appropriate services. This includes smoking cessation and providing guidance on exercise and lifestyle choices. Thank you, guys.